Let me introduce first our first panel of reactor. Our first reactor is a well-esteemed colleague also. He's actually my mentor during my training in UPPGH, Professor Eric Talens. He is currently the Director of Ugnayan ng Pahinugod of UP Manila, Director and past President, Philippine Society of Ultrasound and Clinical Medicine, Incorporated, Faculty Conflict and Catastrophe Medicine, Society of Apothecaries of London, Director and past President, Philippine Society for the Surgery of Trauma. Let me welcome Professor Eric Talens for his reaction, sir.
I'm very glad for the invitation. I'm honored to react to such distinguished lecturers. I've enjoyed their lectures. I'm going to go through each of the lectures, but very quickly give my comments and a few inquiries after that. Well, first, it's a tall order that you gave Dr. Buffard by asking him to discuss control of bleeding. I know that's a whole course in the American College of Surgeons. I think it's a whole day course discussing the organs and all the options. But I think he did elegantly in presenting all the options. It's true in a landmark paper of Russell Gruen, I think is in 2006, we already know that the control of hemorrhage is the #1 error that causes death. That was in the review in Australia. We know that bleeding is really the problem. And I'm glad also that Dr. Buffard mentioned that the real value of factor 17, the good skilled surgeon, they've always told us that, and it's the good surgeon that actually saves the day in these bleeding patients. And well, for the experience in the Philippines, I'm glad in his lecture also, he did a review of all the principles of trauma and the new concepts that we know that now in the recent American College of Surgeons conference we call the acute coagulopathy of trauma. And it's a whole conglomeration of all the things we've learned in the past. The emphasis on the triad of death. It's not the triad of death anymore. It's still the triad of death, but then central to it is bleeding. Stop the bleeding, you stop the whole triad of death. Okay. He also emphasized the importance of delusional coagulopathy, hyperfibrinolysis, and all these concepts. I'm glad you gave us a review, Dr. Buffard. And for the Philippine experience, well, we've had some experience in the control of solid organ injuries, particularly the liver, of total liver occlusion to control bleeding. And we've had some experience and published a few papers on the use of balloons, both the use of Foley catheter balloons as well as fabricated balloons from Penrose drains and red rubber catheters, particularly again for bleeding of the liver. And I'm glad Dr. De La Paz is in the audience. He was with us in all of these papers. And I love your presentation of the wine glasses for it to show TEG patterns. We love that. Never thought of it that way, but I enjoyed that. I too and I'm an advocate of tranexamic acid in this country, and I'd like to thank you for all these reviews that you've given us, all the options you've shared with us. And but one thing's for sure, sir, resuscitation by lactate in my country would be almost impossible. Even our best machines actually don't have lactates in their assays when we do our resuscitation, so it's not available. For the second lecture, Dr. Tumors, I also enjoyed this. In fact, I have a very good impression of trauma centers in Australia because I did some work at the Alfred in Melbourne under Mark Fitzgerald and Russell Gruen, and we used to call it the front room. It's a hybrid room in all essence. Early 2003. It's not called a Raptor yet, but it's in that room. We can do our imaging right there at the table while we do our resuscitation. Now, we don't have experience of these in my hospitals, either in PGH or at East Avenue Medical Center, but we do know the advantages of a hybrid system like this, like the Raptor. It's both expedient and efficient in both resuscitation and in trauma surgery. But the disadvantages, as you have emphasized, is also true. First of which will be the cost to set it up in my country, in a budget restricted environment and setting like us. We'll have to rethink this again. And we also know, if we look at literature and if we've done this, that the convincing outcome data is still lacking, real convincing data. So if you have academics sitting in a panel convincing them to set up a Raptor system, say in the Philippine General Hospital, it will be difficult to do that. And finally, it will be difficult. There's a difficulty in defining patients who will significantly benefit from this. And particularly, this will be useful in triaging them, as you said, in which way they should go. Okay, but in a Raptor system, this would be very, very convenient. Thank you, sir, for your lecture. And yes, sir, we will do our homework if we want to set up a local model in my country. And Professor Resek, I hear you again. I enjoy your lecture. It's so animated. It's so refreshing to hear you, sir. And you are right. In a 2020 meta-analysis, I would recall that's close to 2,000 papers were reviewed, and they already said that whole blood is. They didn't say whole blood is better, but they said that whole blood doesn't actually increase 24-hour mortality compared to component therapy. But then again, they also said that all these studies that they looked at had so much heterogeneity that compiling them together is really difficult to make such solid conclusions. I'm glad you reviewed that for all of us, sir. Fresh whole blood is used in my country, particularly in rural surgery for trauma. And we've seen this. We have our walking blood banks. We have the local government, like the mayors or the municipal leaders, call on people to go there and donate blood directly. We cross-match them and then transfuse them directly, sir. And we've done that. But we'd like to have your opinion as well on auto-transfusion, because we use that in my country. I'd like to hear your opinion right there, sir. We'd love to hear your side of auto-transfusion. And in resuscitation as well, we did some studies before on suspended animation studies, and this had some use as well for the military. Again, I'd like to ask for your opinion on that, sir. And finally, on the report on retained hemothoraces. Well, first, I'm glad that Professor Sangtong referred to Dr. Peter Ree. I've worked with Peter Ree in 98, 99 when I did my fellowship, research fellowship with the Uniformed Services of University of the Health Sciences. And I met him and I worked with him, and I know how he would insist on some things. Now, but you would also recall in 2016, in the American College of Surgeons, they presented a review on comparing, on looking at retained hemothoraces and how it should be managed. Well, first, there's a variation in definitions, no? As to by volume. Is it 1/3 of the chest cavity? Is it a volume of more than 500 ml? In my country, retained hemothoraces, if I put in a chest tube, taken a post-chest tube x-ray, see there's blood still in the chest, that's retained hemothorax. That's how simple we define it in our institutions here. And because of these variabilities, sir, there's also, in that review, there's a variation in the incidence in several countries. That's why there's no consistency. In my country, in a review in 2010, I recall it's less than 18% and 17.8, I think. Now, it's the complication rate that we don't want, and that's what you emphasize. And in my country, the cost for for managing the complications are very expensive, and that also will occupy the bed because of these patients will stay at the hospital for a longer period of time. So again, this will displace other patients. So for us in the Philippine General Hospital and East Avenue Medical Center, we drain as quickly as possible. I know the recommendation is we can wait 3 to 7 days. We drain as quickly as possible, particularly if they're symptomatic signs of like fever, chest pain, even leukocytosis. We look at all these things. But I have a question for you, Professor Santong. Is that, well, what if the patient comes in for it's not a retained pneumothorax, but rather a minimal hemothorax. And we usually define this as a 20% of the chest on one side for a delay of about 1 or 2 days, 24 to 48 hours, asymptomatic. Do we still have to drain this? We don't have any data on these patients and how they will complicate. I'd like to know your opinion on that as well.